Thank God for that. Thank you very much. My name is Mike O'Connor. I'm one of the hip surgeons working at Stepping Hill, and I'm going to talk tonight about the future of hip replacement surgery in the young adult, and why I think the future's looking pink. You probably noticed, but there are lots of pink things that are now occurring. There's even football boots that are pink, worn by Ronaldo and Nani and the likes. God forbid, there's even cricket balls, rugby balls that are pink. The whole world's turning pink. We've got Mr. Bamford's car and Mr. Johnson's car here. Everton away kit is pink. Stade Francais rugby team is pink. Even my son's football team, District Juniors, wear a pink kit because of their links with Christie Hospital. So, not wanting to be outdone, as hip surgeons, we're very competitive. We thought we'd come up with a pink hip replacement. So most of the talk is going to be on this particular implant and why I think it is the future for young adults. But just a brief word about sort of historical things, in the elderly sedate patient, the standard cemented hip as the Exeter or the Charlie still works perfectly well. And certainly if it's done properly, there's no reason why these implants shouldn't last the lifetime of the elderly sedate patient. The real problem for the hip surgeon the real dilemma is, what do you do for the young active patient who has severe arthritis of his hip? And just to give you an example, a very active 70-year-old might walk 1 million steps in a year. An active 40-year-old, this is Mr. Rubin for those people who don't know, in pain by the looks of it. An active 40-year-old may walk 10 million cycles in a year. And we know from historical data that a metal on polyethylene implant in a young person will wear out much quicker because of this increased activity level. So all the companies that make hip replacements over the last 20 and 30 years have spent millions and probably billions of pounds in research and development trying to find the best implant for this particular type of patient. And they are slightly different, younger patients. They have different expectations. They want pain relief, just like everyone does from an arthritic hip, but they want it to be long-lasting. And to have this long-lasting hip, you need to have very low wear rates. The failure of a conventional hip replacement is linked to the wear of the hard metal against the softer polyethylene. But in addition, they want function as well, and this is where they actually want an increased range of movement, and they actually want increased stability, which is completely different demands for an elderly patient, because they want to do things like skiing, they want to do the things they did before they got arthritis, they want to do the things that they think any other 40 or 45-year-old should be able to do. And for a while we actually thought we had the answer in the form of a resurfacing hip replacement or a metal on metal hip replacement. I've got an example of this here. Metal on metal hip replacement were first tried in the 1960s and they all failed, and they basically failed because of the lack of technology in manufacturing. You couldn't get a head manufactured well enough to fit a socket, and they all wore out fairly quickly. Modern techniques have improved that, or so we thought. And the advantage of a metal on metal hip replacement is, if I pass this around later on, you can see that the cup is quite thin, allowing the head to be actually quite large. And we're also told by the scientists that if you match the head with the socket very closely, you actually get a thin film of fluid between the two articulating surfaces, so that you get very little wear. So based on all this evidence, it seemed to be the ideal bearing surface for the young active patient. And lab studies backed this up with hip simulators like this device here, and even the early clinical results also showed that resurfacing of metal on metal hip replacements seemed to do very well in the young active patient. But over the years, some concerns developed. Patients would return complaining of pain of an unknown cause. If we checked their blood levels, we found elevated levels of cobalt and chrome, which are the metals that go into making some of these implants. And it was thought that there was either a sensitivity or a toxicity reaction to these metal ions. In some cases there was massive tissue destruction and pseudo-tumour formation around the hip. It seemed to be more prevalent in the younger patients, and therefore women were more prone to get these problems than men. This is a slide showing what you can find at revision. Widespread metallosis with soft tissue staining and destruction. If we sent these off to the histology lab, they come back showing a vasculitis and lymphocyte infiltration, and it became known as ALVAL. And in severe cases, when the tissue damage was so bad, some of these hips were actually unreconstructable. One hip in particular seemed to do worse than the others, with a failure rate at 5 years of approximately 14 or 15%, which is probably 5 or 6 times what you'd normally expect. This implant has been recalled, and all the patients who've had this implant have been reviewed back in clinic, where we've done blood levels, aspirated the hip, scanned them, and given the option of either close follow-up or revision surgery. Understandably, with this history, the number of metal-on-metal hip replacements has gone like that and nosedived over the last 18 months. As that has happened, the use of ceramic hip replacements has gone up. Now, ceramics were first used in hip replacements back in France and Germany back in the 1970s, and they were either zirconia or alumina. And the properties of ceramics are actually very good for hip replacement surgery. It's non-toxic, it's non-degradable, it doesn't react with body tissues or fluids. It is incredibly hard and scratch resistant, and it can be made to be very, very smooth. And I've got some samples here with a very low surface roughness, and because of this you get very, very low wear rates. Just a graph basically showing ceramic on ceramic with virtually no wear rate compared to a metal on polyethylene with much higher wear rate. So again, if you put this into a younger patient, they will wear it out within a few years. However, again, there were some problems. Cases of fracture. Back in the late 90s, zirconia was taken off the market because of cases of fracture. There have been reported cases of squeaking hips, and if you go onto YouTube and put in squeaking ceramic hip, you will find some really quite impressive cases. The other thing about ceramics is you can't fix the socket directly into bone. It has to have a metal backing. So metal has to go in first, which has to have a thickness, then the ceramic liner goes in. And this combined thickness meant that the head size that you were then putting in was quite limited to being quite a small head. And I'll explain later the advantages of having a larger head. So, a few years ago, a company called Ceramtech in France came out with this lovely pink ceramic hip replacement called Biolox Delta. And basically it was designed to be for the higher demand patient, much harder, much lower wear rates, and thought to have a much greater burst strength because of the worries of ceramic fracture. It consists of a combination of the two ceramics, alumina and zirconia, bonded together, and it's the chromium oxide which makes it the lovely pink colour. And the properties of this new ceramic allow thinner ceramic liners, larger heads which give it stability and range of movement, which again I'll show briefly later on. Gives you a much greater range of neck options, and of course improved wear properties. Now, as orthopaedic surgeons, we are all scientists, and I thought I'd set about setting up a very expensive scientific experiment in my back garden one Sunday afternoon. So I got myself a Biolox Delta head, and I thought I'll test the burst strength of it. And you can see the very expensive equipment: a pair of goggles, a lump hammer, a claw hammer, and an axe. And I do have a video. I'm just slightly wary of trying to play it in case I set off and break the thing, but let's go for it, shall we? I'm sure you're all keen to see what happened.
Yeah.
Yeah. Thank you. This is very much work, isn't it? Oh, here we go. Well, it says full screen. It won't come up as full screen, but so. This is the ceramic ball, this is the lump hammer. That was a gentle tap just to see, and obviously you can see that it's still intact. It gets a bit harder. Can I just say that there were no animals or insects harmed during this video? So 3 fairly hefty taps. The mark on there is actually rust from my lump hammer rather than actually any damage to the ceramic head. So that was quite impressed, so I thought, well, if that won't break it, my axe will. I've got rid of the scream as it hit my leg, but anyway. I do have another video if you're interested, which even a bigger hit. Oh, I'm so pleased these have worked. This is the final one. It's the same head. It's later on in the afternoon after I explained to my wife what I'd been doing. It's still sitting. And this is really quite a healthy whack that I give it. I'm not a small chap, and I did give it a good old. And again, no sign of it breaking. The other experiment that I did do, which I'm not allowed to show you, was I actually hit it with my golf driver. But I only had one attempt at this. My wife wouldn't let me film the second attempt because it nearly broke the patio windows. So back to the talk. So you can see it really is quite a hard substance. Biolox Delta is now being used in a new hip. An example of which is over there called the Delta Motion. And you may think, another new hip, are they mad? Why are they experimenting? But the advantage of this is that the liner and the ceramic itself combined is only 5 millimeters thick. And this means that in a 50 millimeter cup or acetabulum, which would be sort of one that's suitable, or the rough size of a sort of the average female, you can get a 40 millimeter head. And again, I'll show you in the next slide why size of the head is actually important. As we go from left to right, we go 28, 32, 36, 40 millimeters. And by going from 28 to 40 millimeters, you actually get an increased range of movement by nearly 30 degrees, which is really quite important in the younger patient who, as I say, they not only want pain relief, they want function. And again, increasing the diameter increases what we call the jump distance, which effectively is just increases the radius. And for a ball to dislocate, the ball has to be levered out of the joint beyond the radius. So by increasing the size of the head, you're preventing the hip from jumping out of joint. So it really does seem to be the answer. So in summary, keeping it short, following the problems we've had with metal-on-metal hip replacements, it does seem that ceramic hip replacements are now a very good option for surgeons to use in patients who are young, who are active, and have severe arthritis. And the advances in the production and the manufacturing of ceramics has led to the development of our lovely pink hip replacement, Biolox Delta. And this bearing surface now seems to wear less than any other surface available and appears to be the best for the young patient. And because it's new, however, we are only going to hope that this will provide long-lasting pain relief as well as function, even in these young, active, high-demand patients. So, as I said at the beginning, I think the future of hip surgery, certainly in the young adult, is looking pink. Thank you very much.